Welcome back, everyone. This second portion of today's agenda is going to aim at an area of particular interest and work of mine, which is evidence synthesis and its application. And I'm really pleased at the panel and the group of speakers we've put together. So we'll launch directly into that. I'd like to start by introducing Dr. Jonathan Samet, who is a pulmonary physician and epidemiologist and dean of the Colorado School of Public Health. And so for full disclosure, that means he is my dean. His research is focused on the health risks of inhaled pollutants in outdoor air and also indoor pollutants, including secondhand smoke and radon. He's also investigated the occurrence of causes of cancer and respiratory diseases, emphasizing the risks of active and passive smoking. He has served on and chaired numerous committees concerned with the environment, tobacco control, and health. Currently, he's leading the Colorado COVID-19 modeling group, which is modeling the epidemic in Colorado for public health purposes. Dr. Samet was elected to the National Academy of Medicine in 1997 and received the David Rawl Medal in 2015 for his contributions. John, I wonder if I could turn things over to you.
Okay, thanks, Ned, and all said, and great to speak with the committee that includes two colleagues from Colorado. So with that, I will get into the sharing screen thing, and 1 second. So we should be all set. Is that the case? Or let's see. Now we should be. Okay, so thank you for the opportunity to talk with the committee about this topic, which is certainly one that I've spent a lot of time thinking about over the years. I added evidence synthesis and integration to the title because I'm really going to cover a range of topics that are appropriate to your task. In fact, in looking at the task, I want to underline a few points of what you are expected to do. You're going to look at the current evidence, consider turning into an objective and authoritative review of current evidence. And I think as we were reminded in the last session, it's a review with a purpose that's to provide in the end guidance to people who are addressing the concerns and health needs of individuals who have been exposed to this very broad group of agents. In focusing on a few of the specifics, there's looking at the strength of evidence for the spectrum of putative health effects, meaning you have to find the evidence and evaluate what its strength is, and including the likelihood of health effects occurring, which sort of takes you into the range of quantifying the risk in relationship to one or another exposure or dose measures, developing general principles for clinical evaluation of biological testing, given substantial and scientific uncertainty, taking you into the realm of knowing what it is you know and what it is you don't know, how uncertain this are. And then among the items in your specific tasks, also understanding exposure. So this sounds a lot like risk assessment to me, and that's where I'm going to turn my attention to in terms of available frameworks as you consider meeting this task. This diagram was put together for a report that I worked on recently with Liz Boyle, where we were asked to address the methods for review of the EPA's Office OPPT as it carried out its reviews under the TSCA, the revised TSCA Act, Lautenberg Act. And here's what EPA needed to do in relationship to its task of determining the presence of a hazard, looking at exposure levels and thinking about exposure response. On the starting end, of course, in the blue was understanding what the questions were and formulating those questions. And again, certainly a task faced by this committee. Green, those aspects of the job that correspond to systematic review. And I draw your attention to the dotted lines under the green boxes that talk about the different evidence streams that may be relevant: human, animal, ecological, and mechanistic. An evidence integration step, which lies outside of systematic review, for the purpose, and I'll go back over this in more detail, for the purpose of its task, TSCA also, as I mentioned, needed to look at exposure, as will you, and its multiple components, the properties of the agents of concern, fate and transport, human and potentially ecological receptor exposures in general, and building models to estimate what exposures actually are to people. So I'm going to be focusing here on evidence synthesis and evidence integration, and we'll go to the exposure issues as well. Just to get some terminology on the table corresponding to the last chart, I think these kinds of definitions and conceptualizations are probably familiar to all of you, but just so we have some common words. Evidence synthesis, process of bringing together data from a set of included study, those that are identified through the systematic review process, with the aims of drawing conclusions about the body of evidence. And then, of course, going with that, and I know our panelists will come to that, are the prior work of summarizing study characteristics, risk of bias, and the results, and understanding what we know and don't know from the body of evidence assembled, both qualitatively and perhaps quantitatively, using meta-analysis. I think, again, part of your challenge is the multiple streams of evidence that are relevant to your task. I declare that I'm a PFAS naive scientist, and I know there's an awful lot of evidence. Chapter 2 in the ATSDR profile has 550 pages, and I know that Linda Birnbaum referred to a plethora of effects. So there's multiple streams of data potentially for each health outcome that the committee chooses as relevant. And then, of course, evidence integration outside of the systematic review process, but one that brings together the various evidence streams to reach an overall conclusion, I think in your case, related to hazard. Again, multiple schemes for evidence integration, some with long historical roots, and all still grounded in expert judgment. So a little relevant background history. I'd like to go back to the dilemmas that were faced in the 50s and 60s as the observational evidence on tobacco smoking and cancer, particularly lung cancer, emerged. The 1964 Surgeon General's report really represents the first time that our government, to my knowledge, reached a conclusion on the existence of a hazard. That is, that cigarette smoking caused lung cancer in men. At the time, the evidence was quite limited for women. And here's Surgeon General Terry releasing the report, the committee, and at the table, the very large group who put the report together. Now, I think what is important about this report is that there was a plan for evidence gathering and review, and a schema was set up for both studying and evaluating the individual reports, and also for integrating the evidence. And these are the so-called Surgeon General's criteria, if you will, that were applied to make these judgments as to the strength of evidence for causation. Also to be mentioned is Sir Austin Bradford Hill's, quote, 9 viewpoints, which were in a 1965 paper. And I think these two systems for evidence integration have some important parallels, as I'll show you in the next table. In the upper right-hand corner, a famous quote from Hill: "All scientific work is incomplete." He acknowledges that it will always be uncertainty, but a need to act. And of course, that's the dilemma that you face is deciding where does the evidence reach a level of certainty where a recommendation should be made for what a clinician should do with a particular patient. Just lining up these two sets of criteria and setting aside a few of the Hill, there's a mapping. And I will say that in general, the systems that are around, whatever they may be called or termed, trace their origins back to these very thoughtful guidelines from Hill and the Surgeon General's committee. I will say that that in the end they rely on expert judgment. So here we all are, thank God, a panel of experts, and how these guidelines may be applied by different groups, perhaps varied on how evidence is viewed and weighted. But in the end, I think most of the systems to now have involved this sort of expert integration. Now, turning to evidence synthesis, we'll go through evidence synthesis, integration, and the exposure side. Here is back to this chart. And again, I just want to emphasize the need to look at the relevant evidence streams for each of the selected health outcomes. The body of literature is substantial, as you know, and it incorporates a lot of what I'll call the new science, the omics, under the mechanistic data, leading to the question of how, in fact, does one evaluate that line of investigation and integrate it with the others. This same kind of parallel structure is followed in EPA's Integrated Risk Information System, or IRIS program. This comes from a committee I chaired in 2014, setting out a framework for IRIS, where we noted that each of these evidence streams needs to be taken into account as reviews are done. I think for you and for PFAS, there's this challenge of the different streams, as I've mentioned, and this emerging challenge of how do you use this 21st century science, the various omics, whether it's exposomics or lipidomics or proteomics, and so forth. And I think at this point, the idea of systematic review for toxicology, evidence-based toxicology, is still in evolution. I'll mention, of course, that meta-analysis can be useful, the quantitative pooling, if relevant, certainly used in risk assessment for deriving dose-response relationships. As a historical reference, there was actually a nice pooled analysis in a table in the 1964 Surgeon General's report. As pointed out 50 years later, when a group assembled the evidence into a forest plot, is shown on the right. That time, there was a 70% increased risk of all-cause mortality among smokers compared to non-smokers. As I mentioned, the methodologies are being developed for evidence-based toxicology, and I think, again, you can take a look at the recent report on the TSCA methods to find links to this area. The mechanistic evidence and its challenge is one you may face if you begin to use and consider the emerging omics data. Several years ago, I chaired the committee on using 21st century science that addressed these challenges. Report is worth a read, particularly for its discussions around evidence synthesis and integration to provide background. I think the committee did a good job of highlighting some challenges and pointing to the need for solutions. We didn't solve the problems. So going back now to another piece of your charge, exposure, of focusing down in this sort of purplish or pinkish area, we have a number of tasks to be done around bringing together the exposure evidence. And I think, as the last session highlighted, there's not one, but many compounds, perhaps not all well characterized in many dimensions. When we looked at how EPA was approaching this under TSCA, we found that they were challenged. The challenge lay in the fact that methods had not been really previously developed that were systematic review in nature for the circled components here. They were trying, and I think sometimes the fit between systematic review methods and turning, for example, to chemical physical properties or measures of exposure in the literature and in the gray literature was problematic. So again, I think the challenge here lies in the fact that on the exposure side, and I think this was highlighted to a degree in the last presentations, there is substantial complexities to be understood. So how far you will probe into exposure systematically, I would assume, is a topic for a discussion. So looking at then different systems for evidence synthesis, of course, there are a number, and I suspect that in the panel discussion, we may wander into the territory of these different approaches. GRADE, which has been looked at for application to environmental agents, the navigation guide that is by OHAT and others. So I think all of these are trying to deal with the handling of the different evidence streams, the complexities of handling human observational studies, of course, that are non-randomized, and the various inherent biases of observational investigation. So moving on to evidence integration, again, back to our diagram, of course, this sits with the hazard assessment step and is one that you will certainly be concerned about as you grade the strength of evidence for the existence of a hazard as perhaps an important touch point for whether clinical action is needed or not. I mentioned these historic start of evidence integration for hazard assessment for causation, Bradford Hill, and the Surgeon General's reports. There's certainly many others, and these all have the purpose of bringing together the multiple evidence streams. I think for those of you not read the 64 Surgeon General's report, it's available online. I think it was masterful in the approach to discussing the studies, bringing the evidence all together, and providing certainly a conclusion that has certainly stood the test of time. Within EPA, there are a variety of schemes. NTP has schemes. So there are many for you to look at. I do feel like they have their origins looking back to the expert judgment approaches of the Surgeon General's report and Bradford Hill. Potential advances. I've been on committees for a long time that suggested that in the end, we would learn how to use Bayesian methods to bring together different evidence streams. My first National Academies committee was the Biological Effects of Ionizing Radiation Committee number 4, deep in the 20th century. We actually have an appendix there describing the use of Bayesian approaches to bring together animal and human information on risks of a group of radionuclides. We again turn to this in the 21st Century Science Report. I think, the promise remains, the potential needs to be realized. Of course, all the new causal modeling approaches to estimate effects, which I don't really see as directly relevant to your charge. And then, of course, reliance on expert judgment remains. And I think doing that in the most transparent way possible is critical. Then last to your task, the evaluation of strength of evidence, what we know versus ignorance, what we don't know, and uncertainty, the consequence of ignorance. I had to pay homage to Donald Rumsfeld for the quote that will go on forever about the known unknowns and the unknown unknowns. It actually, I think, will remain relevant for a long time. But then comes the question of how do we gauge the strength of evidence? I've edited many reports of the Surgeon General, and in 2004, as senior scientific editor, I led a relook at the 1964 model and the language, because there had not been common terminology set in place by the 64 report. We set out a 4-level hierarchy, and there are many of these now of this sort where the strength of evidence is graded, and there are 4 levels, there's 5 levels, but presumably you're heading to something like this. I think one important question is, how do you frame the strength of evidence around decision making? I'll turn back to another report I chaired quite some time back, where we were asked to look at setting up an evidence-based scheme for providing compensation to veterans. So there, the decision, in a sense, the decision threshold would be to compensate or to not compensate. And our schema for strength of evidence was set up around the idea of equipoise, that there's a balance point, of course, between the existence of a hazard or not, where the evidence stands. And in thinking about compensation of veterans, we felt that they should be compensated if the evidence was at a strength equal to equipoise or above. So here's our proposed 4-level classification, but now set out in a way that would support decision-making. So was the evidence at equipoise and above? Was it sufficient? And then you can see the categories below. Several of our committee members made some very nice pictures about strength of evidence in these plots of posterior probability for an effect, a non-zero effect. And these were corresponding to sufficient with most of the probability mass far away from zero, equipoise and above, acknowledging that there's some possibility of no effect, but a greater possibility that there is one. And then these alternatives of lower strength of evidence. So again, as you think about how you will describe strength of evidence, should you do so, it would seem important to put that in the decision context. I will say, I'm just going to describe one effort to quantify uncertainty sort of more fully. This comes from the Beer 6 committee, which I also chaired and addressed radon. And what we did was sort of a Bayesian analysis of the distribution of probability for different values of the extent of lung cancer attributable to radon. It was an interesting exercise. I'm not going to go into the details, but what we found was, of the many parameters we knew were contributing to uncertainty, after we put about 2 into the model, the whole thing just blew up. So we're seemingly still in the realm of descriptors of qualitative descriptors of the level of uncertainty. Just a last, and particularly with Ned as chair of the committee, I wanted to mention the U.S. Preventive Services task force, which of course has its recommendations that are based around strength of evidence, the level of uncertainty, and also the consequences of benefit. So in a way, I sort of view this as a net benefits assessment. It's almost like a sort of reverse risk assessment, if you will, bringing together a benefits characterization into a schema for action. So it combines some of the elements that I just talked about around risk assessment and a risk characterization, of course, but here the focus is on benefit. So I think in closing, I'm turning back to Dr. Seuss. What to do, and just some last thoughts from me. I think on the evidence synthesis side, there's many models and many that are in use, and I think you need to pick one that's defensible and has a track record. I think toxicology will be a challenge, particularly if you turn to the omics work. Again, in your scoping stage, what are the available reviews as a starting point? On the evidence integration, transparency and replicability, and picking one of these models will be useful. A strength of evidence approach that supports decision making and is tailored to your task. And then for exposure, again, a challenge, but again, transparency being critical. And I don't see that there's a systematic review approach here that's ready for prime time. So I'll stop here and look forward to our discussion. Thanks.
Thanks, John. We have a few minutes for direct questions for you, and I'm going to start. I was writing notes about strength of evidence before you got to that part of the phrase, and I wondered, and I know that we have some real experts coming up on this as well, but can you speak to kind of the way you look at risk of bias and quality of evidence in terms of that strength of evidence setting? So we heard two phrases today that were kind of risk of bias things like residual confounding and reverse causality. And how do those kind of threats to internal validity of the evidence, how do those, in your mind, show up in that strength of evidence assessment?
Yeah. So, there's multiple answers, of course, to the question that, there would be John Samet sitting back and reviewing a body of evidence and sort of rating it. And then comes what we do now, the systematic approaches to risk bias assessment. I think there's still an inherent tension between application of some of the methods, and not to pick on grade, but I'll single it out because of its origins with, the paradigm of RCTs. I think the question of looking across a range of studies and collectively considering the risk of bias is critical. And in a way, and with the evidence integration step, this does come back to the Bradford Hill and Surgeon General's criteria of consistency. I think the sort of upgrading and downgrading that goes on in some of these systems poses challenges. I think you are left in today's world with applying a system, whatever one you may choose as best, for assessing risk of bias. Some of these arguments are not resolvable. Anyone can always holler residual confounding. It's like the unknown. It's like the known unknown. But whether it's important or not is a different matter. And, of course, quantitative exploration of the potential for residual confounding to be a problem is possible, but that's probably not something that's doable within the scope of the committee's time. So sorry to ramble, but if there were a sharp answer, I'd give it.
Thanks. Kevin?
Yeah, thanks so much, Professor Samet. I was curious to follow up toward the end of your talk. It was very helpful. You were giving us these different terms or categories for describing different levels of evidence. You were talking about equipoise and so on. And, in the second part of our statement of task, we're supposed to develop these general principles for evaluation and testing given substantial scientific uncertainty. And I was just curious how you think of that concept of substantial scientific uncertainty. Do you think it corresponds nicely to any of those levels of evidence you were talking about, or could you help us think about how to connect that with the concepts you were providing?
Right. So, one thing that you will do is you're going to interpret your charge. And somewhere in chapter 1, there's going to be the committee's approach. and you're going to say what you think substantial uncertainty is. You're going to have to. And, I think the question of what system you might use to do that is problematic. So if you go back to what, Ned and I were just talking about, does this relate to the potential for bias to affect the body of evidence or of studies that you may view as critical? These kinds of words appear, in fact, in many of these systems, including that used by the Preventive Services Task Force. So I think you're going to need to offer something, and I think that formulation of sort of the more likely than not. So, in that schema I showed you for the veterans, for example, the substantial uncertainty means that there's an equal probability that bias is contributing to the effect that is estimated as opposed to some underlying causal structure. I mean, I think that's what you'll have to do. And I think, again, in the interest of transparency, which is going to be critical because you are in territory where there's no yes, here's what you do. I think you're going to have to say what you're doing and why. So, I mean, I think you put your finger right on one of the tasks. And again, there's some models, but I think just transparency from the start will be critical for you.
Thank you for providing those. That was helpful.